I guess I'm wondering, is there some forum or some mechanism, and I heard three of you talking today, where there can be the kind of conversation and understanding of language and sharing of ideas in a broader context or in a strategic context of how we're going to go about the process of building a healthcare system that in fact has all of those particular components and issues that I think the three of you would want to see in it. Does such a forum exist? If it doesn't exist, how could one go about the process of creating an opportunity to come together to make this thing work?
If I might, I think that our initial meeting is a good start to better understand each other's sectors. What I'd suggest is education before dialogue. I don't normally act that way. I talk and then I go learn about it. But you know, I have to tell you, I've just had a kind of an eye-opening experience. Last Thursday, I was in Anchorage, Alaska. Anybody here from Alaska? No, I know. It's hard for them to come to our meetings as well, time and expense. I went to the Alaska Native Tribal Health Consortium. If you have not been to see that, it is the future. It is the most integrated, now I can't say that I've seen dozens of them, but this is the most integrated public health, patient health, population health. Of course, it's a defined population and it's half capitated, half fee for service. It's unbelievable what they're doing and how they're stretching resources and the numbers they're getting. I think we ought to all get on a bus, not that I'd want to go to Anchorage on a bus, but we all ought to get on a bus, go see what's being done first and what's possible, and then come back and figure out how we build off that, because too often in DC we decide what needs to be done, then we go out and tell the rest of the world, I don't want to do that again. So I think let's find the winners, and let's see what's making them work, and let's see what's common, and then let's see how we can build off those real successes.
So I was, in the early 90s, privileged to participate in a foundation-sponsored, what turned into a 7-year odyssey. And it was around community-based public health. And nobody really knew at that point, except some folks at the Kellogg Foundation, and even they weren't sure once they got into it what community-based public health actually meant. The model that developed, and actually as I look around the room and see who's here, some of the people that I learned about and began to work with then were practiced in that same environment. And one of the things we learned, which would support, Rich, your suggestion, was the importance of going to visit and seeing where things are actually working well. Because it's too easy to sit in your own office and try and figure that out. And it's too easy simply to read about what's going on. But to take leaders from different organizations and different places, put them in a place where something is working so they can see, draw their own conclusions, and then come back and continue the kinds of conversations and discussions that have already been started. Our foundations, by the way, could support this kind of work because it is not inexpensive. But if one looks at the results 20 years later of community-basedness and how much more emphasis there is on community-basedness now than there was then, one can clearly see that that model and that expenditure was value-based and produced successful outcomes.
So like I said, I think the way to really build relationships is through real work. And part of that, the opportunity here is both because of the Public Health Accreditation Board requiring the health agencies to have a community health assessment and a community health plan, and the IRS requiring nonprofits, hospitals to have that. There's a real opportunity to get together to talk about how could we do this together, which the IOM report actually calls for, if you look at the addendum. And we should understand there'll be some false starts, as there actually has been in this area, because there's the two initial questions are, why do you people care and what do you have to do with this? Not realizing each other has great expertise and a true interest. And I'm the expert, what are you doing here? Not, again, realizing each other has expertise. And we'll have those false starts, but we ought to keep working at it. And I think this is a great opportunity to bring the hospital and healthcare sector and the public health sector together into, and I just want to add one correction, to a health system, Scott, because you slipped in healthcare there too. It's come so naturally, a health system. So I would really welcome that opportunity. And as you said, the first step is really the education. So we understand the expertise each side has and the inherent interest each side has, and we don't both come in beating our chest as if we are the experts.
Thank you very much. As Rich said in his remarks, public health and medical care, hospitals, there's a long history, many, many chapters in it. I was in Rochester recently, and Dr. John Noseworthy, who's the president of Mayo, reminded me that one of the two Mayo founding brothers, I think it was Charles, in addition to founding the Mayo Clinic, also was the local health director for that community and county. And was that in that role for many years because he saw the connections. He saw the connections. And there's a long history of what they did to promote health in that part of Minnesota. So there are many chapters. Some have been very productive and perhaps some not so. But I think where we are today with Rich's talk and Bobby and Paul's remarks and being here together at Keeneland, I think really we're at the cusp of another new chapter in public health, hospital, medical care collaboration that I think can be very exciting and very beneficial for everybody, and most importantly for the communities that we all serve together. So with that, thank you all very much, and we stand adjourned.